Hi and Assalamualaikum. My name is Nurul Nadhirah Binti Azmi from class HS2446A regarding two articles written by Buitrago et al. In 2019 and Schnackers et al. In 2018, given by Dr. Ida Hasni for this assignment. I have prepared presentations on interventions and integrating motor learning principles for children with cerebral palsy. During this presentation, I will critically evaluate, compare, and synthesize the components reported in those two articles. Also, throughout the presentations, I will describe the principles of human development, the concept of motor control and motor learning, and international classifications of functioning, disability, and health, which is the ICF model in pediatric rehabilitations. Furthermore, the purpose of these presentations is to determine which interventions is more effective between the two articles written by Buitrago et al. And Schnackers et al. In therapeutic interventions of motor learning among children with cerebral palsy. First and foremost, we need to know the definitions of motor learning. Alright, motor learning is a phenomenon that refers to relatively permanent neuromotor changes leading to the acquired ability to perform motor skills. It is actually a series of internal processes that associated with practice and experience. Such changes ensure that the objective is achieved. They are derived from experience and practice, resulting in acquisitions, applications, and maintenance of motor skills. However, motor learning can be measured by improvements in performance, which can be seen to increase and correct errors of executions and to decrease the durations of tasks. According to Schnackers et al., cerebral palsy is a group of permanent neurodevelopmental disorders of movement and posture that causes activity limitations, thus attributed to non-progressive disturbances that occurred in developing fetal and infant brain. The study objective as reported in these two papers, first and foremost, Buitrago et al. In 2019 reported that their study objective is to validate the effectiveness of a 16 sessions of physical therapy programs. Also, they want to improve the participations and fulfillment of therapeutic objective on an 8-year-old boy with dyskinetic cerebral palsy for motor learning to walk using a social assistive robot. Meanwhile, Schnackers et al. In 2018 reported that their study objective is to improve the bimanual skills of the child whilst minimalizing the increase of therapy-related parental stress using home-based training programs. The study design conducted by Buitrago et al. In 2019 is a single case study where the subject participated in the study was single participants. The interventions and outcome measure were based on the selective participants and subject being conducted in the study. Next, Schnackers et al. In 2018 reported a study protocols as their study design, where the authors describe the interventions using protocols that follows the template for intervention descriptions and replication guide, where both therapists and parents were engaged and having coaching sessions throughout the intervention program. It is also a COAD study, which is a collaboration between universities. Actually, it is a mixed method, which is a multi-method research consists of quantitative and qualitative research. Meanwhile, in my opinion, study design such as randomized control trial with a control group that offers different interventions may produce comparison, which in return help the researchers to investigate the effectiveness of the treatment. For example, a home bimanual interventions and may produce better outcomes. After having some thoughts, I would prefer study design reported by Schnackers et al. In 2018 because the study used protocol along with the two interventions as reported, and the direct coaching and interactions among the therapists, also parents, according to the aspect needed in the protocols helps producing better quality of the child performance. Moreover, the settings for Buitrago et al. In 2019 is a gym settings, as the research study was conducted at a gym in a neuro-rehabilitation center where the participant attended his physical therapy session twice weekly for 16 sessions, whereas Schnackers et al. In 2018 conducted their research study mainly at home settings of bimanual training for 12 weeks. In my point of view, Schnackers et al. In 2018 reported a better study settings because it involved home-based intervention session where the implementations of the intervention programs on the child was individualized and adjusted specifically according to their home environment, thus empower the parents to be more attentive and directly participate in the treatment sessions. According to the study conducted by Buitrago et al. In 2019, the research study reported a participant, which is an 8-year-old boy with disconnected cerebral palsy. The child having level 3 in the gross motor function classification system, the manual abilities classification system, and the communication function classification system. The authors also check on the medical history of the child, which reporting no health complications, and he able to interact with the environment, was able to understand the immediate context. The study does not provide a clear exclusion criteria as they only stated the inclusion criteria of the child. Basically, the authors went through a process where they chose the subject based on the medical history of the child that regularly attended physical therapy during the last 3 years. Meanwhile, Schnackers et al. In 2018 in their study reported that the target population is children with unilateral spastic cerebral palsy, aged 2 to 7 years old, with manual ability classification system level 1 till 3 and gross motor function classification system level 1 till 3. In my opinion, the authors provided the readers with unclear information regarding the inclusion and exclusion criteria of their target populations. I would prefer the participants or subject included in Schnackers et al. In 2018 because the target population age varies does lead to a larger sample size which may produce more results and better interpretations of the effectiveness of the interventions. Next is the study procedure. The procedure of the 16 sessions of intervention program by Buitrago et al. In 2019 started with a recognition section where the child met the robot and interacted with it to avoid any negative impact on the first therapy session, such as distracted or decided not to attend the proposed rehabilitation process. Alright, the first session was basically a conventional therapy that focused on the child's motor control skill, whereas the second session was a therapy that fulfilled the objective motor learning to walk using the humanoid robot as social assistants. The alternations of conventional therapy and therapy using humanoid robot was implemented throughout the 16 sessions of intervention programs. The therapy routine can be summarized as the therapists are directing the therapy and the child's role is to participate by interacting with the robot, also environment. This activity was performed for 30 to 40 minutes in a gym where the child could walk for more than 20 steps. In my opinion, including the parents throughout the treatment session would offer better outcomes as it provides the direct interactions among the caretaker and therapist, thus improving the level of understanding and independency of the parents in improving the current conditions of the child. Alright, besides, the study procedure for the two interventions conducted by Schnackers et al. In 2018 consists of two phases. The first phase is preparation phase that was conducted for 2 weeks where they set goals for the next phases, which is actual home-based training. In addition, during the preparation phase, they conducted an introductory meeting between the parents, also child, with the coaching professionals, where the remedial educationalists examine the aspects of the interactions and behavioral domain. Also, therapists and parents discuss thoroughly the family situation, also their home environment related to the rehabilitation goals, and they also did recorded an observational video of the child's performance of activities corresponding to the needs. Next, the therapist designed an individualized program by addressing treatment goals decided by the therapist and parents. Parents will be instructed about home-based training, specifically through instructions, videos, and a manual. Then, a home visit by the coaching therapist took place where they discussed the general outline and examined home situation for the individualized program. Alright, second phase took place where the actual training of the children lasted about 3.5 hours per week of bimanual training, and it was performed in a way that was embedded in family routines. Besides, video recording of the training sessions once a week will be shared by the parents through a digital communications for the coaching team to analyze and suggest improvement. The parents will register the training programs, the training activities performed at a digital form, which is the Excel sheet, for the coaching team to obtain information, which is a daily basis registrations, is for whether the training activities were performed, and weekly basis registrations for the experience of both child and parents. Next, the tele-coaching over phone at the start of each week will be conducted for a small standard evaluations to take place where parents may ask questions or addressing any difficulties and problems during training sessions. The upcoming week program content is formulated based on the video recording and registrations. Home visits will be conducted by the therapists at week 5 and week 9 of the home-based training. Both intervention programs may implicit and explicit learning in a home-based training programs contrast respectively to the coaching strategy. In the explicit program, parents are instructed to give exact instructions and feedback of the motor performance of the bimanual activities, while implicit program use both hands and appropriate motor performances of the child for the activity are elicited via manipulations of the organizations of the activities. In my opinion, the interventions program could be better if the therapist and coaching team explaining the exact activities they implemented, as the article does not report clear activities they have done. Alright, Schnackers et al. In 2018, in my opinion, reported better component in terms of study procedure compared to study conducted by Buitrago et al. In 2019, because it was conducted in a more detailed manner and provide better understanding on the reader on how they conducted the activities, and parents' direct participations also contributed to a better outcome of the intervention. Next, the variables being analyzed in a study by Buitrago et al. In 2019 is motor learning and social assistive robots. The independent variable is usage of social assistive robot on dyskinetic cerebral palsy child, while the dependent variable is child's motor learning abilities. In addition, the variable being analyzed in the study by Schnackers et al. In 2018 is binual child abilities in unilateral cerebral palsy and parental stress. The independent variable is the binual child abilities, while the dependent variable is the level of parental stress regarding the motor learning abilities of the child. In my opinion, the variables reported by Schnackers et al. In 2018 reported better component because they chose the level of parental stress regarding the child's motor learning abilities, which is, in my opinion, essentially important in rehabilitation care of children with cerebral palsy. Parental stress led to a better home training, thus enhanced health outcomes and also reductions of healthcare costs. The outcome measure in a study by Buitrago et al. In 2019, as reported, are Goal Attainment Scale, which is GAS, which quantifies and evaluates results in objective. It is a scale that allows setting individual objective and is sensitive to minimum changes, while Schnackers et al. In 2018 used Canadian Occupational Performance Measure, COPM, child adapted version in the study. COPM is a semi-structured interview for parents where they identify and rank the child's perceived problems in self-care, play or leisure activities over phone by the therapist who is experienced in the COPM, as well as clinical practice in pediatric rehabilitations. Next, the coaching therapists transform the most important needs into SMART goals using video recordings and use GAS to formulate predetermined criteria for the rehabilitation goal progressions. Alright, in my point of view, Schnackers et al. In 2018 provided the readers with a better component in outcome measure because the combinations of COPM and GAS in the study would increase the sensitivity of the results. The study result reported by Buitrago et al. In 2019 found that the child managed to increase the number of steps carried out continuously during the training mediated by the human and robot. The first evaluation on Section 5 showed that the child able to reach the number of steps proposed by the objective with +2 on the GAS scale. The second evaluation, which is on Section 11, reported +1 on the GAS scale, and third evaluation conducted on Section 16 showed 31 steps were observed and +2 on the GAS scale. Basically, the persistence in the walk can be the factor that determine the achievements of the proposed objective. 11 weeks after the study, another evaluation was made by another professional who did not participate in the study and found that the child able to walk 100 steps without falling. Schnackers et al. In 2018 in the study did not clearly mention the results of the study, but they did report that they strive to resolve the challenges encountered from previous studies, such as improve the parental stress and reductions of therapy compliance over time. Besides, resolving the challenges by coaching the parents not only with respect to bimanual performance of the child, but also parent-child interaction during practicing. In my point of view, Buitrago et al. In 2019 reported better result component compared to Schnackers et al. In 2018, but both studies should improve their results components by explaining the results of the outcomes measure being used on the subjects. In addition, there are several limitations in the study conducted by Buitrago et al. In 2019. Firstly, it is unclear statement if the increase in the number of steps without falling due to the modifications and persistence generated by the presence of human robot or methodology proposed and developed or to a critical moment of the child's motor learning because of the therapeutic process that had been carried out before these interventions. Second limitation is it was not specified on the number of attempts should be met in each intervention sessions and the expected number of attempts, thus a bias in evaluations may occur due to unsystematic measuring details. The third limitation can be seen on the positive 2 GAS scale that had been reached on session 5, where the definitions of new objective was made, but the task or the environment was not modified. The limitations in the study of Schnackers et al. In 2018 can be seen as they did not provide a clear evaluation process of the home bimanual training. Besides, the effectiveness of the programs on the child and the impact on the parents needed another case series to be carried out as it was not reported in the current study. In conclusion, after going through both of the articles, the intervention approach by Schnackers et al. In 2018 will be chosen and preferred the most because they reported a better component compared to Buitrago et al. In 2019. To support my opinion, few proof can be seen after critically evaluate, compare, and synthesis the study design, settings, the participants' recruitment, the study procedure, the variables or parameter being analyzed, outcome measure, results, also study limitation, where Schnackers et al. In 2018 reported the better components. Besides, the intervention program, which is bimanual home training, including parents' role directly in the training sessions, attract and gain my attention, also interest, because increasing the parents' participations lead to a better understanding and educate them regarding the child's conditions and current performance. Basically, parents spend more time with their child compared to the rehabilitation team, so direct participations of the caretaker or parents in treating the impairment and problems enhance the chances of effectiveness of the intervention programs on the child. That's it. Thank you.